All right, so we've been really getting into these GLP-1 receptor agonists lately and how they kind of change things up for anesthesia care.
Oh, yeah, for sure.
We're going to break down this pretty in-depth multi-society clinical practice guidance specifically about using these GLP-1 RAs safely when patients are going into and coming out of surgery.
Yeah, these guidelines are brand new from the American Society for Metabolic and Bariatric Surgery, and they're really trying to get a bunch of different specialties all on the same page about managing this new group of medications.
It really feels like every day there's another GLP-1 RA coming out, which is awesome for patients.
Yeah.
But it's definitely a steep learning curve for us as providers. The big thing everyone's asking is how do we take these guidelines and make them into a process that's easy to actually use?
Exactly, and luckily the guidance really comes down to a simple three-step algorithm that you can start using right away.
Perfect. So let's walk through it step by step.
Sounds good.
So first up, understanding the risk.
Yep.
We know GLP-1 RAs are amazing for managing diabetes, obesity, even heart failure. But they do come with that one kind of weird side effect, right?
Right, and it's something that we just can't ignore when we're talking about anesthesia.
Yeah.
GLP-1 RAs make the stomach empty slower than usual, which is normally not a problem, but when you're about to go into surgery...
Yeah, then it's like a recipe for disaster.
Exactly.
We're talking pulmonary aspiration, and these guidelines even mention actual cases of it happening in patients on these medications.
Which is why having a clear plan of action like this algorithm is so important. It can really make all the difference.
Okay, so let's dive into that first step, assessing the risk.
All right.
What should we be looking for that tells us a patient on a GLP-1 RA might be at a higher risk for complications?
So there are 5 main things to think about.
Okay, lay it on me.
The first one is whether the patient is in the phase where their GLP-1 RA dose is still being increased.
Okay.
So if they are, the risk is generally higher than if they've been on a stable dose for a while.
Yeah, that makes sense. Their body's still getting used to the medication. What's the next red flag?
The second one is the dose itself. The higher the dose of the GLP-1 RA, the greater the chance of side effects in the GI system, including that delayed stomach emptying that we're worried about.
So dose matters, got it. What else?
The third thing to look at is how often they're taking it.
Okay.
So think weekly doses versus daily doses. The weekly ones seem to cause more GI issues, maybe because the medication levels go up and down more.
So higher dose, less frequent dosing, both potentially mean higher risk.
Yeah.
Got it. What are the last two we need to consider?
The fourth one is pretty straightforward. Does the patient have any symptoms affecting their stomach? Things like nausea, vomiting, belly pain, constipation, those can all be signs that their stomach is emptying slower than usual.
So we really got to listen to our patients and take those symptoms seriously and not just brush them off as side effects of the medication.
Right. Okay, what about the last risk factor? This one is about looking beyond the GLP-1 RA itself. Are there any other conditions the patient has that could also slow down their stomach emptying? Like problems with how their bowels move, or gastroparesis, or even Parkinson's disease?
Yeah, it's like a perfect storm scenario where all these different things could add up to a much higher risk of aspiration.
Exactly.
Okay, so really getting a good patient history is super important. We need to know everything going on with them to be able to assess the risk accurately.
Yeah, I totally agree.
All right, so we've talked about that first crucial step of risk assessment. We've gotten all the info, we've looked at those 5 key risk factors. What comes next?
Now we get to the really important part of the algorithm, which is managing the risk.
Ooh, this is where it gets interesting, right?
Yeah, especially for CRNAs, who are really the ones taking care of the patient before, during, and after surgery.
Before we get into managing the risk, though,
Yeah.
I think it's worth pointing out why this algorithm is such a big deal for CRNA.
You're right. That's a good point.
Before this, there really wasn't a clear agreement on how to handle these patients on GLP-1 RAs. There was a lot of gray area, and every provider was making their own judgment calls.
Yeah, I think that's fair to say.
And any CRNA will tell you that can lead to inconsistencies in care and even put patient safety at risk.
Absolutely. This algorithm provides a standardized way of doing things that helps CRNAs make informed decisions and feel more confident in their approach.
And I imagine it also helps to have those conversations with surgeons and the rest of the care team go more smoothly.
Definitely. It gives you a solid foundation for talking about your concerns, discussing different options, and ultimately coming up with a plan that prioritizes patient safety without forgetting about their metabolic health.
So CRNAs out there listening, this algorithm is a powerful tool you can use. It brings clarity, consistency, and confidence to your practice. Okay? I'm ready to tackle step 2, managing the risk. Where do we start?
Okay, well, first, it's important to remember that this is all about making decisions together. We as CRNAs have to work with the patient, the surgeon, and the doctor who manages their medications.
Collaboration is key. Got it. So what are some of the options we have for managing this risk of aspiration in patients on GLP-1 arrays?
One option is to stop giving the GLP-1 array for a bit before the surgery, but we have to be careful about that and weigh the benefits against the risks.
You mean we can't just stop the medication without thinking about what might happen?
Right, exactly.
Yeah.
Stopping a GLP-1 array suddenly could cause dangerous spikes in blood sugar or other metabolic problems, especially in patients with diabetes.
So it's about finding that balance between making sure they don't aspirate, but also making sure their blood sugar and other metabolic things stay under control. So holding the medication is one option. What else can we do?
Another strategy is to use a short-acting medication to kind of bridge the gap when the GLP-1 array is stopped.
Okay, so that helps with those concerns about metabolic instability. What other options do we have?
The guidelines also suggest thinking about having the patient on a liquid diet for at least 24 hours before the procedure,
Okay,
similar to what we do for colonoscopies or bariatric surgeries.
makes sense. Less food in the stomach means less chance of aspirating it. What about using technology to help us figure things out?
That's where things get really interesting. Using ultrasound right at the bedside to look at what's in the stomach and how well it's emptying is becoming more and more popular.
Wow, so we can actually see how much is in there.
Yeah,
That
exactly.
seems like a game changer.
It definitely helps us make better decisions, but the guidelines do point out that not every hospital has access to this technology, and there's always the chance of human error when interpreting the ultrasound.
So it's a great tool, but not a perfect solution. Are there any other ways to manage this risk?
The last piece is the anesthesia plan itself. If we're really concerned about aspiration, then using a rapid sequence induction for general anesthesia might be the best way to go.
Now, most CRNAs are pretty familiar with rapid sequence induction, but can you just quickly remind us why it's so important for patients on GLP-1 RAs?
Sure, the goal is to get that airway secured as quickly and safely as possible so there's less time for anything to be aspirated.
So it's all about speed and precision.
Exactly.
We pre-oxygenate the patient, give them a fast-acting induction agent, and then immediately paralyze the vocal cords to make intubation easier.
Precisely. And just like with any other intervention, the decision to use rapid sequence induction has to be made by talking with the whole team and weighing the benefits against any potential risks for that specific patient.
So we've talked about stopping the GLP-1 array bridging therapy, changing the diet, using ultrasound, and considering a rapid sequence induction. That's a lot of options.
It is.
What's the last step in this algorithm?
Step 3 is communication and documentation. It might seem boring, but it's absolutely critical for patient safety and making sure everyone knows what's going on.
I know documentation isn't the most exciting part of our job, but you're absolutely right. So what are the key things we need to make sure we document in these cases?
We need to write down everything about how we assessed the patient's risk factors for delayed stomach, emptying the decisions we made about managing their GLP-1 RA, and why we made those decisions.
So basically, we're making a clear path for anyone else who's involved in the patient's care. If we decided to stop the medication, we explain why. If we went with a rapid sequence induction, we say why. It's all about being transparent.
Right, and just as importantly, we need to document any conversations we've had with the surgical team and the doctor who prescribed the medication.
Got it. We want everyone to be on the same page about the patient's GLP-1 RA therapy and any changes we made to the plan for the surgery.
Exactly.
Okay, so this algorithm is giving us a fantastic framework for handling these cases.
Yeah.
But as we all know, every patient is different.
Oh, absolutely. These guidelines are super helpful, but they shouldn't replace our own clinical judgment. We have to tailor our approach to each individual patient's needs and what's going on with them.
I'm curious, what are your thoughts on how this algorithm can actually be put into practice in different healthcare settings?
That's a great question, and it's something that every CRNA should be thinking about. Let's talk more about that in our next segment.
Sounds good.
So to really make this algorithm work well, it's all about making it fit into your specific work environment.
So it's not like a one-size-fits-all kind of thing.
Right.
What could that look like in a super busy pre-op clinic, for example?
Okay, so picture this. A surgeon is about to do a laparoscopic cholecystectomy, pretty standard, right?
Yeah.
And the patient just so happens to be taking a weekly GLP-1 RA to help them manage their weight.
Okay, so we've got a patient on a weekly GLP-1 array, already a risk factor, and they're about to have surgery.
Right.
What do we do first?
It all starts with that really thorough pre-op assessment we were talking about before.
Right?
We got to get the patient's medication history, their dosing schedule, and find out if they've been having any GI symptoms.
And don't forget about any other conditions they might have that could make things worse.
Exactly. We need the full picture to use those 5 risk factors from the algorithm and really figure out the patient's overall risk.
Okay, so let's say in this case, the patient mentions that they've been feeling a little nauseous and throwing up sometime since they started their medication.
Okay, now we have 2 risk factors, weekly dosing and GI symptoms. So this patient is now in a higher risk category for delayed stomach emptying.
So what happens next? Do we tell them to stop taking the GLP-1RA right away?
Not so fast. Remember, it's all about making decisions together.
Right.
We need to talk to the surgeon, explain our concerns about aspiration risk, and discuss all those different management options from the guidelines.
I'm guessing the type of surgery and how long it's supposed to take also plays a role in that decision-making.
Absolutely. A longer procedure means the patient has to fast for longer, which could cause more problems if we stop the GLP-1RA completely.
Yeah, we don't want to solve one problem just to create another. Managing the risk of aspiration, but maybe messing up their blood sugar at the same time.
Right. It's all about finding that sweet spot.
So for this cholecystectomy, let's say the surgeon is okay with going ahead without stopping the GLP-1RA. What do we do then?
Well, we have a few tools we can use to try and lower that aspiration risk. In this case, it makes sense to recommend a liquid diet for at least 24 hours before the surgery.
Okay.
Less solid food in the stomach, less chance of aspirating. Pretty simple, but it works.
What about that point-of-care ultrasound? Would that be helpful here?
For sure, we could use it the morning of the surgery to actually look at what's in the stomach and how much is still there.
Okay.
If it looks like there's a lot, we might have to talk to the surgeon again about maybe delaying the surgery or considering a rapid sequence induction for general anesthesia.
So basically, we need to keep talking to the surgeon throughout this whole process.
Yeah, having open and honest communication can't be stressed enough.
Yeah.
It's so important to talk through the risks and benefits and sometimes even have those tough conversations to make sure we come up with a plan that really puts the patient's needs first.
Okay, so this algorithm gives us this structure for making decisions, but that's not the whole story, right?
Right, you're exactly right. Working together, talking openly, and being willing to adjust things for each patient is what really makes this algorithm effective.
And let's not forget about the patient themselves.
Oh, yeah, for sure.
We need to include them in these conversations too.
Absolutely. We need to educate patients about the potential risks of taking GLP-1RAs around the time of surgery and give them the power to be a part of the decisions about their care.
So shared decision-making isn't just between us healthcare providers. It's about making the patient the center of it all.
I couldn't have said it better myself. Informed consent is essential. Patients need to understand the risks and benefits of each option so they feel good about the plan we develop together.
This whole conversation really shows how complicated healthcare is these days.
Yeah, it really does. We're dealing with complex medications, a wide variety of patients, and we're always learning new things about how different conditions and treatments affect each other.
And that's exactly why these multi-society guidelines are so valuable.
I agree.
They give us a map for navigating this tricky landscape, but as we've talked about, the journey doesn't end there. It's up to us as healthcare providers to take these guidelines and actually use them to create individualized care plans for each of our patients.
That's the key.
And that takes clear communication, a willingness to work together, and a commitment to staying up to date as this field keeps changing. We've covered a lot so far, but there's one more important point from these guidelines that we should touch on before we wrap things up.
You're right. It's super important to remember that these guidelines aren't set in stone.
They're more like a living document, always evolving, as we learn more about GLP-1RAs and how they affect the period around surgery.
The authors of the guidelines even say that new types of anti-obesity medications that come out might mean we need to change the recommendations in the future.
It's like they're giving us a peek into what this field might look like down the road.
Yeah, exactly. And it really highlights how important it is to stay on top of things, keep learning, and adjust our practices as new research comes out.
So CRNAs listening, this is your call to action. Don't just read these guidelines and put them aside.
Right.
Really dive into them. Talk about them with your colleagues and think critically about how you can make them work in your own workplace.
I agree.
And most importantly, stay curious. This field is changing so fast, and we need to keep up to make sure we're providing the safest and most effective care for our patients.
Speaking of staying ahead of the curve, let's move on to our final segment where we'll explore those beyond the algorithm considerations.
All right, so we talked about what this new GLP-1RA algorithm is and how to use it. But before we finish up, I'm really curious about those beyond the algorithm things you mentioned.
Oh, yeah.
What should CRNAs be thinking about as this whole area keeps changing so fast?
Well, one thing is that making this algorithm actually work in different places is going to be different everywhere you go.
Right. No cookie-cutter solution here.
Exactly.
So what are some ways CRNAs can actually put this algorithm into practice in their own hospitals and clinics?
I think it all starts with just being aware of it.
Okay.
CRNAs need to take the lead in teaching their surgeon colleagues and everyone else on the care team about these new guidelines.
So spreading the word, making sure everyone's on the same page. What else?
Hospitals could think about creating standardized forms for the pre-op assessment that specifically ask about GLP-1RA use.
Ooh, I like that having a dedicated section on those forms would remind everyone to do a thorough check for those 5 risk factors we talked about.
Right.
It could even make things more efficient in those crazy busy pre-op clinics.
Exactly. And imagine if those forms were connected to the electronic health record system.
Cool, getting fancy.
They could automatically flag patients who might need a closer look or a consult with an endocrinologist.
Now that's taking it to the next level. It feels like technology could really help make this algorithm run smoothly.
Absolutely. And on a bigger scale, collecting all this data in a standardized way could help us spot trends and patterns in our patient population.
Interesting. So we might start to see if certain GLP-1RAs or certain types of surgeries are linked to a higher rate of delayed stomach emptying.
Right. And then we can use that data to make our protocols even better and make smarter decisions about managing these patients in the future.
So it's not just about using the algorithm. It's about always checking to see if it's working and making improvements.
Exactly. It's all about creating a system where we're constantly trying to improve the quality of care.
And that takes teamwork, right?
Totally.
We need open communication, not just within our anesthesia teams, but with other specialties too.
Absolutely. CRNAs need to be talking to surgeons, endocrinologists, even primary care doctors to discuss these guidelines and figure out the best way to make them work together.
It's about breaking down those walls between departments and collaborating to make sure we're doing what's best for our patients.
Exactly. That's what it's all about.
Well, we've covered a ton of ground in this deep dive.
We have.
From the science behind GLP-1RAs to the actual steps CRNAs can take to keep these patients safe.
Yeah.
Any final thoughts you want to leave our listeners with?
I think it's really important to remember that these guidelines, even though they're focused on managing risk, also present a huge opportunity.
An opportunity, tell me more.
GLP-1RAs are changing the game when it comes to treating metabolic diseases like diabetes, obesity, and heart failure. These medications have the potential to really make a difference in people's lives.
And these guidelines give us a framework to use these amazing tools safely and effectively.
Exactly. They're like a bridge between innovation and safety, helping us to embrace new therapies while still making sure our patients are safe.
That's a great way to wrap things up. CRNAs out there, embrace the challenge, have those important conversations, and never stop learning.
I agree.
And to our listeners, thanks for joining us on this deep dive into the world of GLP-1RAs and anesthesia care. Until next time.